Good afternoon, my dear colleagues, ladies and gentlemen. Welcome to join the Symposium on Pediatric Pulmonary Hemorrhage, Symposium on Pulmonary Hypertension. It is my great honor and pleasure to introduce the next speaker, Dr. Jinwei Lu. Dr. Lu is an experienced young pediatric cardiologist in Taiwan. He was graduate from the National Taiwan University. After medical education at the Taiwan University, he postdoc training at the Laboratory of Molecular Cardiology, Baylor College of Medicine, Houston, Texas, United States, from 2002 and 2003. Currently, Dr. Lu is the assistant professor of the Department of Pediatrics, National Taiwan University, and also he is the director of the Department of Pediatrics, Hsinchu branch of National Taiwan University. His most experience on adult congenital heart disease, especially the GORCH with a complete congenital heart disease with pulmonary hypertension. So today, he is one of the best speakers for the congenital disease with pulmonary hypertension. So Dr. Lu, please start your talk.
Thank you, Chairman. Today my topic is about pulmonary hypertension in CSD after Fontaine operation. The multi-stage Fontaine surgery, introduced about 45 years ago, is a tremendous progress in the treatment of patients with single ventricle. The first stage operation, such as Norwood procedure, can keep the pulmonary vascular bed away from injury due to high pressure and high flow, at the same time to enhance the growth of pulmonary arteries. The stage 2 bidirectional gain shunt can relieve the ventricular volume load by directing the flow of SVC into pulmonary artery. The final stage of operation connecting the IVC and the PA can separate two circulations and relieve cyanosis. The benefit from Fontaine circulation is to restore normal systemic arterial oxygenation, and it can also relieve valve overload from single ventricle. But the cause is it can cause lower cardiac output, and the passive non-pulsatile venous flow to the lung without ventricular pumping can cause systemic venous hypertension and pulmonary artery hypotension. The pulmonary circulation in Fontaine acts as a dam between systemic vein and the ventricle. It can cause upstream congestion and downstream decreased cardiac output, and therefore cause the cardiac and atriocardiac complications in Fontaine patient. The pulmonary vascular resistance is the primary modulator of cardiac output. When PVR increases a little, the cardiac output drops dramatically because of insufficient ventricular filling, no matter how good the ventricular performance in Fontaine patients. Because many clinical trials using the result of exercise test as an endpoint, we will introduce the exercise performance in normal subject and the Fontaine circulation. As exercise in normal subjects, the cardiac output can increase 3 to 5-fold due to greater preload, increased heart rate, increased myocardial contractility, and reduced afterload. Because in Fontaine patients, there is no RV to provide this work demand, so the LV filling and the cardiac output are unable to increase normally. Even the Fontaine patient with very good ventricular performance, the exercise level is paid is about 50% of normal subjects. And another important phenomenon in Fontaine circulation is the PVR can change with age. When the Fontaine patient becomes aging, the PVR will increase. It can cause even higher systemic venous pressure and lower cardiac output. And through the pathological study from the Fontaine patient, study with the autopsy from soon after Fontaine patient and a group B patient with long-term die after Fontaine operation, and they also collecting the H-match control. They found that in patient died soon after Fontaine operation, their pulmonary vascular bed revealed medial muscular hypertrophy. However, in patients died long after Fontaine operation, they found the pathology of pulmonary arteries revealed eccentric acellular intimal fibrosis with thrombosis and decreased vascular smooth muscle cells. And we can see that compared to H-match control, the intimal layer thickness is increased with age. That is different from the pathology observed in idiopathic pulmonary arterial hypertension or PAH after left to right shunts. These two kind of patients had medial layer thickening, but in long-term Fontaine patient, they found the thickening layer is intimal layer. What caused the PVR in Fontaine circulation increase over time? The first reason occurred before the Fontaine completion, because there is possible excessive pre-Fontaine pulmonary flow or pulmonary artery hypoplasia distortion and the stenosis of pulmonary arteries before Fontaine completion. Those can also cause increased PVR. And because there is no positive systemic venous flow direct to the pulmonary arteries, there are many clinical undetectable microemboli can cause increased PVR. And the main reason with PVR increase over time in Fontaine patients is the lack of positive flow in Fontaine pathway. It can cause pulmonary artery endothelial dysfunction, such as impaired shear stress medial release of many endothelial vessel-active molecules such as NO, and the increased apoptosis of vascular smooth muscle cells can impair the pulmonary artery vasodilatation. And the chronic hypoxemia in Fontaine patients can cause hypoxia-induced factor targeting gene encoding for pulmonary artery hypertension such as endothelin and vascular endothelial growth factors. And because the pulmonary artery pressure in Fontaine patient is rarely above the 20 millimeter mercury, that's the definition of the pulmonary artery hypertension. There is in need of another definition of pulmonary hypertension in Fontaine patients. The European Pediatric Pulmonary Vascular Disease Network defined a new definition for elevated PVR for Fontaine circulation. They define PVR index above 3 or transpulmonary gradient above 6 millimeter mercury as pulmonary hypertensive vascular disease in Fontaine. However, the measurement of PVR in Fontaine patients is often difficult and sometimes misleading because there are many patients of Fontaine circulation with sustained venous to pulmonary venous collaterals or fenestration. It can hamper the actual estimation of the PVR in Fontaine. So the better measurement method is to determine the pulmonary blood flow by cardiac MRI and measure the pressure by cardiac cath to avoid the misleading results. Now, how about the pulmonary vasodilators in Fontaine circulation? Let's check out the result from the real clinical trial. In short term, pulmonary vasodilators such as sildenafil or prostaglandin. There are two short-term trials showed a significant increase in exercise performance and echocardiographic cardiac performance after sildenafil short-term use. And for the prostaglandin, there is a variable effect of the inhaled alloprost and treprostinil. Alloprost showed increased oxygen consumption and peak VO2 pulse. But for the inhaled treprostinil, there is no effect on venous pressure and liver stiffness after exercise. For some small-scale long-term trial, the sildenafil and the bosentan showed variable effect. The sildenafil showed it can reduce the VCO2 slope at an anaerobic threshold, but the VO2 during peak exercise was not different. But the echocardiographic performance was improved after the 6 weeks of sildenafil. Another study using bosentan for 6 months showed no difference in VO2 max NT-proBNP after bosentan use. And another small-scale study using bosentan and macitentan showed improved cardiovascular hemodynamic and exercise performance. The abrisentan can also increase the VO2 max and decrease VCO2 slope during exercise. And the most important two long-term trials involving bosentan and sildenafil. We will see more detail about these two important clinical trials. The TEMPO study involved 75 Fontaine patients from 4 centers in North Europe. When they gave 14 weeks of bosentan, the exercise performance using oxygen consumption during peak exercise showed improved about 3.5% compared to 2.1% of placebo group. There is a significant difference, but the difference is not large. The secondary endpoint is the duration of exercise stays from 6 minutes to 7 minutes. Although it's different from the placebo group, but the change is also not a lot. When we see the recent field trial involving 400 adolescent Fontaine patients from 30 centers in North America and Korea. They use Unionfield for 26 weeks. We can see the oxygen concentration during peak exercise changed a little, 2.8%, did not reach significant compared to placebo group. However, the secondary endpoint about anaerobic threshold increased a little compared to placebo group, with a significant difference, but not very much. So, from the clinical trials of the pulmonary vasodilators in Fontaine circulation, we know that pharmacological manipulation of Fontaine circuit is extremely challenging, partly because the mechanism and the pathology of PAH in Fontaine is different from the idiopathic pulmonary artery hypertension. So the medication targeting pathogenesis of Fontaine with PAH may be more suitable for Fontaine patients. There are also many unanswered questions from these clinical trials. Is there a role in patients with Fontaine failure, or can these vasodilators can decrease mortality? What kind of Fontaine patient may benefit from vasodilators? The longer the better. Or is the prophylactic use of vasodilators helpful? Which drug is more effective and safe for Fontaine? This we all not know. In conclusion, the PVR is a key determinant of cardiac output in Fontaine patients, and it can increase with age. That's why the pulmonary vasodilator may be benefit for Fontaine patients. Although the clinical trial was performed so far, the safety and the well-tolerated results encourage us to use the pulmonary vasodilators in Fontaine patients, but the results of clinical trials shows variable and marginal improvement in exercise capacity and the hemodynamic profiles, and the impact on long-term prognosis is still unknown. Thank you very much.